So my name's Tahmina. I'm a lecturer in biomedical science at the University of Salford. Prior to stepping into academia, I was working at the Christie Cancer Hospital in Manchester for 12 years as a HCPC registered biomedical scientist. I became specialised in haematology and blood transfusion after completing the IBMS specialist diploma. And then I went on to complete my master's in haematology and transfusion. That allowed me then to progress to a more senior role as a biomedical scientist, team manager and blood sciences training officer. I then began to work a bit more closely with the IBMS as a verifier and examiner for registration and specialist portfolios, CPD officer, non-accredited degree assessor. And then after a few years of completing qualifications in training, quality management and leadership and management, my role expanded to pathology training coordinator, which covered histology, cytogenetics, blood sciences, the mortuary and the bereavement services. I am also a National Council member of the IBMS. Today I've got Aimee, who is a senior lecturer in biomedical science at Staffordshire University. I'll let her give you some background on her career journey and then we can make a start onto the more interesting bits. Over to you, Aimee.
Thanks, Tahmina. Hi, everybody. Nice to be with you all today. We've got this event set up because a few months ago, I want to say about 6 months ago now, we did an hour where lots of different specialists from all the different specialisms came together and we were just inundated with questions. So hopefully today's session gives you a little bit more depth about what's involved in haematology and transfusion. And as Tahmina said, I'm quite happy to take questions throughout. So to give you a bit of background, I've got some slides later on a bit more depth on my career, but my name's Aimee. I'm a senior lecturer at Staffs Uni and very similar background to Tahmina. I specialised in haematology and transfusion at Royal Stoke University Hospital, which is part of the North Midlands NHS Trust. Really busy trauma site, and I'm going to try and give you a flavour of some of the things that I would come across in my day-to-day role as we go throughout. Yeah, and I think I'll save the rest of the career stuff for throughout, just because it makes a bit more sense where I've placed it. Tahmina, is there anything before I get going?
No, thanks, Aimee. You can make a start, and I'll keep an eye on the chat as well.
Great, thank you.
So whenever you have opportunity to answer, I can read that out.
Thank you. I think what we'll do for all the students who are in is we'll pause about halfway through to take some questions. I can see lots of different people joining and things pinging in the chat, but while you're talking, it's a little bit difficult to keep track of. So I will try and get to everybody's questions and hopefully I'll answer some of them as we go through. But if not, make sure you ask me at the end or follow up with an email to me. So today I'm going to go through with you a bit of an overview. Hopefully you'll find out a bit more about what's involved in haematology and transfusion, including the tests and the various subspecialisms. Within each specialism in pathology, there are several subspecialisms and you can go really highly specialised if you want to, or if that's what's available within your lab. So I'll go through some of what you might expect there. A day in the life, so what my typical working life looked like while I was in the NHS. And that differs really from department to department and trust to trust. So just keep an open mind about some of that. I'm going to talk a bit about quality throughout, various career routes, and give you a flavour of some case studies that we might come across in haematology and transfusion. And hopefully you'll pick up some tips on preparing for an application or an interview throughout. And that will vary depending on which point you're at in your degree, or indeed if you're post-degree and you're looking to get into the field. If you're a first year, I would still say that all of this is relevant to you and that you can't be prepared too early on. I was interviewing for my placements at the end of first year, beginning of second year, so it's never too early to start, essentially. So one of the questions that I get asked all the time, and I thought I would just start with because this is the first of the specialism sessions, is what do you actually have to do to work as a biomedical scientist? I'm going to try and keep this brief so that we're not just taking time away from reviewing the specialism. But you will need an IBMS accredited degree, and hopefully you all know whether your degree is accredited or not. But if you're not sure, you can find out from your university tutors, you can find out from the university website, and you can also find out from your IBMS website, which gives a list of all accredited courses. On top of that, you then need an IBMS registration portfolio. So this is often what we call the portfolio, and it can only be completed in an IBMS accredited laboratory. So lots of people complete that during a placement year. Some people complete it during a shorter placement, which is what I did. I did a 14-week placement. And then other people complete it after their degree. Completing that registration portfolio is what allows you to apply for the HCPC Certificate of Competence, and you have to be HCPC registered to work as a biomedical scientist. You might work as a scientist in other labs without that, but you cannot legally say you are a biomedical scientist without HCPC registration because it's a protected title. So hopefully that clears that bit up. So your degree alone for any of us working as a biomedical scientist is not enough. As I've already said, placements are really important for these roles, but you can complete it after graduation too. And if you're in the room today and thinking, oh, well, my degree isn't actually accredited, there are options there as well, because you can do top-up modules afterwards, which mean that your degree can be assessed by the IBMS. They'll tell you what gaps are missing from the accreditation, and then you can top those up to convert your degree essentially to something that would make you eligible for HCPC registration. While I'm on the topic of the IBMS and the HCPC, I was asked about both at all of my interviews, as a medical laboratory assistant, as an associate practitioner, and as a trainee biomedical scientist. So make sure you know the difference between the IBMS, which is your professional body and is here to represent us as biomedical scientists, protect the profession, promote education of the profession and so on, and the Health and Care Professions Council, which is our regulatory body, and that's there to protect the interests of the public and to make sure that our patients are okay. Can I just ask, if you're not speaking, if you could just put yourself on mute for me, please? I think it might just be someone who's just joined, just to get rid of the background noise. Thank you. So a little bit about my career to date then so far. So I did an accredited degree from 2012 to 2015. Oh, I'm just going to stop a second and find out who that is so I can mute them.
I'm just looking through the list, Aimee.
There we go. I think I've got them. Thank you. It's just a lot of background noise coming back, isn't it? Yeah, so I did my degree 2012 to 2015, and over my summer and Easter breaks, when you would normally have quite a long gap from university, I suppose, I went and did my placement hours. So I worked at a small district general hospital called Leighton Hospital, and I rotated around all of their different pathology specialisms. So I knew pretty early on that I was leaning towards haematology and transfusion, but it wasn't at that point necessary for me to know. I could have completed my registration portfolio in any of those specialisms and still being eligible to work in haematology and transfusion afterwards. So when I graduated, I was then eligible to register with the HCPC. But for a few months before that, I'd been lucky enough to get a trainee biomedical scientist post. And there's a little loophole, I suppose, in the NHS where without your HCPC registration, you can't work as a biomedical scientist, but you're still eligible to apply for the post as a trainee. So I worked on something called Annex 21, which is part of the NHS that allows you to wait for that pending qualification and registration. My first trainee role was in anticoagulation, which I'll come on to in a moment as a subspecialism of haematology. But I knew I wanted to get the broader scope of haematology, and I knew I wanted to work somewhere really busy, somewhere that gets a lot of exposure to different cases. So in November 2015, a few months after graduating, I moved to Royal Stoke Haematology and Transfusion as a Band 5 biomedical scientist and worked my way up from there. Once I moved to a specialism once I moved to haematology and transfusion in a busy trauma hospital, I was pretty much straight away on the 24/7 shift rota, and that's something that you have to expect with some specialisms, particularly haematology and transfusion, biochemistry, but it's becoming increasingly common across all of the specialisms. So I'll talk to you later about the type of hours that I worked for those shifts. I then spent the next 6-7 years at Royal Stoke, and during my time there I completed the IBMS specialist portfolio, I completed an MSc in haematology, and I worked my way up through being a specialist biomedical scientist onto a deputy senior biomedical scientist post. So that's moving more towards things like the management and quality type positions. When I finished my MSc, I did that alongside working, and I started doing guest lecturing at Chester, which is where I did my MSc. And I found that actually I didn't mind public speaking. I used to hate it. And then I found that I didn't mind it at all. So that was when I started to take my first steps into working as an academic. And I used to work at Salford University as a teaching fellow, which I loved. And I wanted to do more of that. But at the time, it was very difficult with lots of things going on with COVID and all the challenges in the NHS to come off the shift rota. And as any of you who've worked shifts in your part-time roles might know, it's very difficult to balance your life with shifts alongside everything else that's going on. So I decided that I would come out of the labs permanently at that point, and I accepted a full-time post here at Staffs University, and then I started my professional doctorate as well. So that's like a PhD level qualification, looking at specifically the impact of biomedical scientists. So it's a little bit off topic from haematology and transfusion, but just to give you an idea of where some of your careers might go, and to sort of point out to you that it's very wide open. You can do lots of things in the labs that will be transferable outside and vice versa. So back to the labs. When I was in haematology, after a few years of being in haematology and transfusion, I decided I would like to specialise in morphology, which is the picture of me next to the microscope there. Morphology is looking at the changes in the size, the shape, the number, the type of cells that are present on a blood film. So when we take a blood sample from somebody, we can spread it onto a glass slide and stain it. And then we look down the microscope for any of those cell changes. And I was particularly interested in white cell malignancies. So as part of that, I did my IBMS Higher Specialist Diploma in haematology. That's one of the higher level qualifications that you can do to specialise in the labs. And I completed that early in 2020. That meant then that I was working with lots of different haematology and oncology patients, and I specialised in acute myeloid leukemia and the diagnosis of a whole range of other leukemias. Stoke is one of the bigger cities in between Manchester and Birmingham, so we get a lot of patients in from across the Peak District and all sorts of areas like that, meaning that you had a really varied role, and that was something I really enjoyed. As I mentioned, it's also a large trauma hospital. And again, being one of the bigger cities in between Birmingham and Manchester, we provided all of the trauma care for North Wales. So we used to get air ambulances coming in quite a lot. Lots of accidents in the Peak District, so farming accidents and biking accidents, quite common around the Buxton area. And we would see lots of different types of traumas coming through. So if any of you have ever watched the A&E type programmes that are popular on television now, there is one called Critical Condition for Royal Stoke, and you'll see the type of trauma work that comes in. And I think sometimes the role of haematology and transfusion is really downplayed in those, which is a shame, because we're involved in nearly all of those cases. So if somebody comes in and they have unknown bleeding or they have a major bleed, one of the first things that the medical team will do is supply blood products to them, and that was all the background work of haematology and transfusion biomedical scientists. So if that interests you, then this specialism might be something that grabs your attention. I thought it was a good point to point out as well that there's a real evolving emphasis on molecular techniques and immunophenotyping. So what cell markers are present on the cells in order to improve our diagnostics and prognostics, and that's coming through more and more in haematology. So a knowledge of those type of things, if you're interested in that, is starting to play a day-to-day role in someone's work in haematology and transfusion. So I'll give you a broad overview of the subspecialisms now and the type of tests that might come up in these. Again, this is useful for those of you preparing for interviews, either for placement or for permanent positions after university. I was asked about the subspecialisms in my interviews. So perhaps the busiest area is the automated section of haematology. So haematology is a nice mix, I think, because you have a lot of automation, which is necessary because of the number of samples. The hospital that I worked in would process upwards of 3,000 full blood counts a day. So clearly you couldn't do all of those one by one, hand by hand. But we also have lots of manual tests too, which I'll come on to. So a full blood count, if most of you have had a blood sample taken in the past, you've probably had a full blood count done. And this looks at all sorts of things in your blood. So it looks at your hemoglobin, it assesses your red cell count, your white cell count, and your platelets. So it's a good indicator of general health, and it can be used to point out a lot of different diseases like iron deficiency anemia. It can help pick up on things like the leukemias that I talked about, and then general monitoring of different patients. So things like chemotherapy patients or ward patients. We also did ESRs, which is an erythrocyte sedimentation rate, and that's when blood is taken up into a tube and we measure how long it takes for the red cells to drop down the tube or to sediment. And the rate of how quickly the red cells do that tells us a lot about the patient's inflammatory processes or about their anemia and so on. Similar test is the plasma viscosity, and this was used for myeloma patients mostly, or patients with something called Waldenstrom's macroglobulinemia, and it's where patients are making too high levels of immunoglobulin, and it makes their cells sticky, and we can test that because their plasma becomes more viscous then. So there's a range of tests done in that area. And again, depending on which trust you're in, that's also where things like malaria tests were processed in the hospital that I worked in. My point for that section is it's a really high throughput and it's busy. So there are lots of different people working together in that section. There are usually quite a lot of medical laboratory assistants, associate practitioners keeping the analyzers going, and then the biomedical scientist doing the technical and clinical validation of results. So technical validation is when we check that the result fits what we expect from an analyzer. We say, that doesn't look quite right. That looks like the analyzer might have a bit of a clog in it, or the reagent might not be quite right. And then there's clinical validation. And that's when we've said, yes, the analyzer's working fine, but clinically that picture doesn't fit. So someone's dropped their hemoglobin quite quickly. Why is that? Do we think they're having a bleed? Do we think there's a malignancy? Do we think there's some sort of hemolytic anemia going on? And so on. So that was really interesting because you had a large number of samples coming through constantly and lots of different things to think about at once. What normally happens if a full blood count needs further examination is that we move on to morphology then. So only about 1 to 5% of full blood counts get a blood film made, and again that varies depending on the clinics that are coming through that day, the experience of the staff and the department themselves. But blood films can be made, and they can also be sent away for further testing at genetic specialist sites. So that wasn't the case at Stoke. We would send them away to Birmingham or to Manchester, but the larger hospitals tend to have these specialist genetic sites too. We could also look at bone marrow in morphology, and we might also look at other fluids such as peritoneal dialysate, so the fluid from patients who are on peritoneal dialysis for their kidneys, or cerebrospinal fluid in cases where we were suspecting some sort of infiltration of the brain tissue, lymphomas, for example. So that was a really interesting section, and I've talked to you a little bit already about the type of work I did in there. We also have the coagulation section of haematology, and this is where we're assessing somebody's ability to balance clotting and bleeding. So we don't want to go too far either way. If you think of clotting and bleeding as being like a seesaw, we don't want the balance to tip one way because then you'll clot too much and you'll make pathogenic blood clots, so things like deep vein thrombosis. And we don't want the balance to tip the other way, because then you'll bleed too much. And that's when we see patients like haemophiliacs. So in the coagulation section, we can assess somebody's factor levels. We can assess how well they are clotting normally, and also how well they are clotting when we're treating them with drugs to prolong their clotting. So, for example, if we are putting a patient on heparin after surgery, we want them to take longer to clot, and we need to be able to assess that the drugs we're giving them are working in the way that we want. So normal clotting and abnormal clotting that we expect. That section is more towards anticoagulation. So anti being the opposite of our normal coagulation processes. We can give drugs like warfarin and the newer DOACs or NOACs that you might have heard of, things like apixaban, and we can monitor those from the coagulation section. The final sort of section of haematology is grouped into special testing, for want of a better word. And this is where we look at things like hemoglobinopathies, so sickle cell patients, beta thalassemia patients, and there's a national screening programme for a lot of the hemoglobinopathies. So depending on the prevalence in your area, that can be a really large part of testing, and also stem cell counts as well for patients who are going to have stem cell transplants. Then blood transfusion is sort of an entirely separate area, but in a lot of trusts you work across haematology and transfusion, which both myself and Tahmina did. And again, like all the other sections, very busy. Every patient who comes through the hospital for surgery should have a routine group and screen done. So that means that we check what their blood group is. And the reason that we do that is so that if they need any blood products supplied either during surgery or post-operatively because of anemia, we're able to do that. We're also screening to see if they make any antibodies to some of the common antigens, so to make sure that we can have special compatible blood available for them. In addition to those routine pre-op patients, we have a significant amount of antenatal work that goes through blood transfusion. So you have screening bloods done at various points throughout your pregnancy, again, to check that you're not making antibodies which could be harmful to the baby. They can cause something called fetal disease of the newborn. That can be fatal in severe cases. So it's a really important part of the work. And then obviously working in a trauma hospital, emergency blood products support, that might involve something called the flying squad, which I think is just one of the best names ever for the O negative blood supplies that a hospital will carry, and they can be provided as universal donors to patients, and also supplying different factors like factor VIII concentrate to haemophiliacs and so on. So hopefully that gives you a good overview of the types of tests and the types of subspecialisms that you might go into. As a biomedical scientist, a generic biomedical scientist within haematology and transfusion, I rotated around all of those sections. And what that meant was that no 1 week ever looked the same for me. And that was something I really enjoyed about my specialism. I thought this would be a good point to mention specimen reception as well. So for most labs, there will be a central specimen reception where all of the different specimens that are taken will come to. And if you're trying to get experience in a lab or in a hospital, you're wanting to go on to working as a biomedical scientist after, I can't recommend enough that you try and get into a specimen reception, even if it's just for a tour, because it's a really important part where you'll learn a lot of the test repertoire and a lot of the pre and post analytical implications. So thinking about the types of samples that would be loaded onto an analyzer, that's a picture of our automated track at Stoke, with all the samples ready to be sent off via machine to different analyzers, via different blood samples collected into different tubes. This is something that I was asked when I went for an associate practitioner job. And basically all of the different coloured blood tubes have different additives in them. And that allows them to be used for different tests. You can find all sorts of information about this online, but I'm going to take you through the 3 key ones now for haematology and transfusion. So I'd say by far our most common one is the purple top, and this contains EDTA, which is an anticoagulant. So it stops the blood clotting once it's been taken out of your body. It means it stays fluid in the tube, and that means we can use it for full blood counts, ESRs, blood films, and so on. A very similar sample is the pink top, and that's mainly used in blood bank. It's got exactly the same EDTA additive, but it's a bigger tube, and that means we can get a bigger sample volume from the patient, because quite often in blood bank, we need to perform additional testing at a later date. So we do that initial group and save or group and screen, but then we'll also do things like cross-matching, direct antiglobulin test, and so on. And then for coagulation, we have the separate blue blood bottles. So these contain sodium citrate, and that's a reversible anticoagulant. So EDTA is irreversible, but sodium citrate is a reversible anticoagulant. So when we add calcium to the tube or to the sample later on in the lab, we're able to initiate clotting, and we're able to get a good measure then of what's going on in the body. So we perform our coagulation screens, D-dimers, which is a product of clot breakdown, tells us whether somebody's likely had a clot, and also factor assays on these. What's really important, and you can't really see it on the tube, but you would be able to on the back of this, is that running around here, I don't know whether my highlighter might work or not, whether you can see that or not, just below where it says Vacutainer, I've drawn like a highlighted line, and there's a frosted line on these tubes. And it's
Aimee.
Does it work? Great, thank you.
Yeah.
So that frosted line is really important to tell us whether there's enough sample in there, because we need the right ratio of blood sample to the anticoagulant to make sure that when we're testing the clotting, we're not just measuring an anticoagulant from a tube. So why am I mentioning these things to you? Well, they're really important, that we know that the pre-analytical variables are correct. So we know that we're processing the right sample for the right patient at the right time, and that applies to all pathology specialisms, which is why I would recommend any of you going into specimen reception. It's also a really important part of your IBMS registration portfolio assessment. So as part of the registration portfolio assessment, you complete 30 pieces of evidence, and you also have to give a lab tour to an external assessor. And some of the things that they assess you on are that you know the correct procedures for handling specimens, pre and post analysis, and also that you know how to operate the equipment used in preparing the samples. So you know how to centrifuge those blue blood bottles, for example. You know how to make sure that the frosted line is filled to the correct level, and so on. I'm about halfway through now, so just before I move on to the sort of day in the life and case study type things, are there any common questions coming through that it would be helpful to answer at this point?
I have been keeping an eye on the chat. There isn't anything in there, so I'll just remind the students, if you do have any questions, please do type it in the chat, and then we can always address them. Thanks, Aimee.
Yeah, great. Okay, thank you. If not, I'll stop again at the end in case anybody's got any questions. It was just in case anyone had anything burning at that point. Right, so a bit about the day in the life. So I mentioned before that all blood scientists usually have to work shifts. For me, this was either a core day, so 9 till 5:30, 6 till 6 in the morning till night, or 6 p.m. in the evening till 6 a.m. in the morning. Usually over weekends. The night shifts for us were always 12 hours. The day shifts were only 12 hours on a weekend. I might have worked 6 in the morning till 2 in the afternoon, 12 midday till 8 p.m, or pretty much any combination thereof. So different hospitals will run different shifts. They are usually voted for by the team. They are usually well established, and there's usually some flexibility there if needed for childcare, etc. But the people who I worked with who had children had to work some combination of them. They might just not work them Monday to Friday, for example, depending on what their partner was available for to provide childcare and so on. So I guess what I'm saying there is, if you're considering haematology and transfusion, you need to make sure that you can make some aspect of shift work alongside your life. I typically rotated around all the different subspecialisms throughout the week. As I became more advanced as a biomedical scientist, I was often working in morphology because that was where I had a role within the senior team and also where my area of specialism lay. But I still worked throughout all of the others in order to maintain competence. And that means that you get a really highly varied week. You get to work with different people every day because not only are the biomedical scientists working on shifts, the associate practitioners tend to work on another shift system and the medical laboratory assistants work on another shift system. So in a typical day, it wouldn't be unusual for me to cross over with maybe 15 different people in the same department. And that means you're constantly giving handovers or accepting handovers because of that continual nature of lab work. I worked with a mixture of samples from GPs or community clinics, from the wards. As you can imagine, a trauma hospital is busy and has lots of different wards. So I would see things like chemotherapy wards, kidney wards, liver wards, and so on. And each of those different patient subsets has quite different presentations. So learning what's normal for a GP is not normal for a ward patient and so on. And then, of course, all of the emergency work. So that was really interesting to me because nothing was ever really the same. So I've got some examples to show you now the type of things that we would see coming through and to try and show you as best I can without going into a lab what you might see in haematology. So first off is these various red blood cell VHC plots, and these come off our automated analyzers in haematology. These are from an analyzer called the Siemens Advia 2120i, and that's just the analyzer that was used at Stoke. So what you can see in this one on the top left corner is this section that I've just highlighted in the middle. The sort of centre bit of the plot is where we would expect most of your normal red cells to be. As we go up the y-axis, the cells are getting bigger. And as we go across the x-axis, the cells are getting more and more dense, so they're getting darker. And that indicates that they've either got more haemoglobin or they're perhaps more dehydrated. And then the shape of the plots tells us quite a lot about the patient. So this one here, the bottom left is normal. Most of the cells are inside that central box that I was telling you about. But we can see along the top left row, we've got a beta thalassemia trait where we've got smaller cells than we would expect. And we can also see an iron deficiency plot with this typical right angle here, showing that the cells are small and pale because they haven't got enough haemoglobin in there. In this bottom middle one, we can see two different populations of cells. So hopefully you can see that one there and the second there. And that's where somebody's been transfused. So somebody's got something wrong with their red cells, we've transfused them, and that second population is the normal amount. We might also see it when we've got things like cold agglutinins, and that's the image on the bottom right. So our cells stick together, and when they go through the analyzer, it thinks they're in population 1 because they're too big and they're too dense. And then when we warm it, we get a separate plot. So you can see lots of different things from the analyzers. And I think sometimes people think the analyzers are just pressing buttons all day. But I just wanted to highlight that that's not really the case. So when I talked before about technical validation, here's an example of what I mean. So we have software that links the analyzers with our reporting systems. And this is where we check whether we think technically those results are correct. So you can see on the right-hand side the various plots. You can see the red cell plots. And then this one here, which I'll highlight round again, is one of our key white cell plots. And there shouldn't really be that many cells in there. For a normal adult, we expect your white cell count to be up around 10, depends on the reference range of your laboratory. And this adult had 117.4 as their white cell count. They're in respiratory failure, and they've got a lot going on. They've got no platelets. There's lots of things that we can see on there that in a normal patient we would think, oh, that doesn't look right at all. I've just seen someone say they can't see the slides, Tahmina. Can you still see the slides on yours?
I can see them. Is anyone else
Okay.
having the same issue? No, I've got thumbs up, so
Okay.
I think others can. Yeah.
Okay, I'm sorry to who can't see them then, but I'll just carry on if everybody else can, and I'll take back the control from that as well. So yeah, you can see lots of different things in this technical validation stage. When that then comes over to our reporting software, we're looking at different things again. So we've already said at this point that we know the results technically correct from the analyzer, and now we're trying to figure out clinically what's going on. So this is quite a concerning one. This is a GP patient, and the only clinical details we had through with this are that it's a routine patient. So a routine check of whatever is going on in their health. As a side note, if any of you do go off into medical practice, please don't say things like routine or checking bloods on clinical details, because it's the most unhelpful information to be given. So this patient is flagging for something called an MPO deficiency. Myeloperoxidase is what we use to measure the granularity of cells on those analyzers. And this is saying they've got a deficiency. So in this section here, which I'll highlight, where we're looking at the differential of white cells, the analyzer can't count them. It's counted them all as large, unstained cells, doesn't know what they are. And that's where we'd need to look at a blood film. Luckily, this patient case was just a genuine myeloperoxidase deficiency. It wasn't lots of blasts or atypicals, as the flag would suggest. But you can see they've got other problems going on. They've got quite a low hemoglobin, a low platelet count, so they are genuinely unwell. And that's the type of variety I'm talking about in what you would see. There's lots of different indices to understand at once, and you can see how all of your learning from across your degree and then the training on the job all supports that. Just got a few blood film pictures to finish off the case studies section before I go on to some quality and some tips for interviews for you. This is a severe iron deficiency anemia patient, and this is the type of cells that you would see down the microscope. So you can see things like pencil cells, which are this one here. They literally just look like a squished pencil. You can see Burr cells like this one here with the little spiky projections. You can see that the area of central pallor is too high, really. And again, these are all skills that you would pick up during your training. And then the final morphology picture, because they're my favourite, is to show you some acute leukemia cells. So these are the cells on the left-hand side image, which are really big, they look really angry, and you can see some hour rods in them. So these are cells that shouldn't be present in your peripheral blood in a normal patient. And also chronic myeloid leukemia on the right-hand side. So we've got maturation to end stage at this point. We've got maturation from blasts through to neutrophils, but we're seeing way too many of the cells. They're not in the right number, they're not in the right proportion, and they haven't matured as we'd expect. And again, that's another, I think, interesting aspect of the type of work that goes on in haematology and transfusion. I wanted to touch now on quality because it's such an essential part of any lab role, but it's something that I would commonly ask about if I was interviewing somebody, and indeed in all of my own interviews at various levels I've been asked about quality. So if I was you at this point, I would find it really useful to go and read about QC and EQA schemes. So QC is quality control and EQA is external quality assurance. That's a way of checking that all of the samples and the results that we're sending out from a lab are genuine, that they're the right result for the right patient at the right time, and it'll be a key part of your role no matter which blood sciences lab you're working in. If you're working in a very small lab, you'll still have to do QC and EQA at the same proportional amount as a large lab. Ongoing training and CPD are really important. So if you think of just the few examples of cases that I've shown you there, there's lots to know about lots of different things. And as part of that, you are expected to keep up your continuing professional development, engage with things like this that you've attended today, engage with lectures, go to lunchtime journal clubs and so on. And that would be a key part of your role. You'll also have continual competency assessments as a biomedical scientist, and that's to check that you've got the right knowledge that you need at various points. So, for example, those blood films that I've just shown you, I wouldn't expect someone coming from university to be able to identify all of those cells, but I would expect after a period of training in morphology that they're able to identify them. So then we're looking at what point are you competent to be working independently, and are you maintaining that competency? So there's no use passing the test at the start of your career and then not being able to recognise the cells in 2 years' time. A really key one that you'll have, I imagine most of you would have questions on in an interview, is UCAS accreditation. So that's the United Kingdom Accreditation Service, and we are accredited as pathology labs to a standard called ISO 15189. Something slightly different for point of care testing, but they are related and they've been brought in line with one another. So have a look at those standards and what's involved in the assessments. And then also for transfusion, we have things like the MHRA, which is the Medicines Health Regulatory Authority, and Vanessa, which is a blood stocks control system, checks what levels are across the country, and that's when you see adverts coming out for things like O negatives in short supply, please come and donate. It's really important that we can keep track of the various quality aspects throughout a lab. There's lots more that I could talk to you about there, but in the interest of time, I'll keep to those key ones. So to finish off, just some top tips on how you might want to go about finding a post and how to improve your application for those posts. So think about your experience, think about which specialism you want to be in, but also think about which type of hospital you want to work in, what type of shifts you want to work, and think about the experience that you've already got. So some jobs are very broad, and you can use your experience from various part-time roles to support your job applications. So for example, I was a waitress while I was in college, then I worked in an NHS call centre while I was first in university before I worked as a medical laboratory assistant, and loads of those jobs had transferable skills. So things like working under pressure, working in a busy team, working shifts. I worked as a delivery driver, so I talked about, managing my own workload, making sure I was timely on arrival for things. It doesn't have to be lab experience to show that you've got experience of a particular skill. If you've got lab experience, then obviously that's great, but if not, please don't exclude yourself from things. There are job adverts going out all the time. When I checked this morning on NHS jobs, there were over 100 different biomedical scientist jobs, and each of those job adverts will usually give you a named contact for the lab. You can reach out to them, you can try to get in touch to see if you can go on a lab tour, you could ask them about placements or work shadowing. In a lot of cases, in all honesty, you won't get a response because they're so busy, but what's important is that you take a proactive approach and keep trying. There are also lots of graduate schemes, so I know some people are interested in things like the scientist training programme. That leads to a slightly different area from biomedical science. That leads to a role called clinical scientist, and you can find lots more out about that outside of the scope of this talk, really. So when you're looking at job adverts, make sure you meet the entry requirements, and you can do that by checking the person spec and the job spec, treating them as a tick list and making sure that you address those points that they want. You'll score higher in your applications, you're more likely to be shortlisted, and therefore you're more likely to reach interview. A lot of people ask me whether doing a master's would benefit them. I personally am glad that I waited to do my master's, because I then did a master's in an area that I knew I was interested in and I knew I was already specialising in. But that doesn't mean to say that you shouldn't do the master's straight after. What I would encourage you all to think about is the content of the course, whether it's accredited or whether you need it to be accredited, and whether it will help you in the long run. And also make sure you get involved in networking. I've had so many opportunities come to me through networking, whether that's been the guest lecturing that got me into lecturing in the first place, or whether it's been to go along for different lab tours. It's a really good way to keep up with policy changes as well. So a good place to start with something like that is the IBMS chat on Twitter. I'm sure there's one running tonight. Yeah, it's first Wednesday of the month, so there will be. They're 8 till 9 p.m. on Twitter. You can search the hashtag and go back to find loads of tips for interviews or placements and so on. It's just a really good way to get in touch with the biomedical scientist community. And then on your applications, think how many people apply for these roles. Check it, and check it again. If there's typos and common mistakes littered throughout, but you're saying you've got a good attention to detail, that suggests you probably haven't got a good attention to detail. So check it. Think about the skills that you can give examples of that you've developed at uni or part-time work, extracurricular activities. And like I said at the start, for those of you in first year, I don't think it's ever too soon to have your CV and cover letter ready now. Lots of your university staff, I know both me and Tahmina, will do mock interviews for our students. We'll give you examples of common questions, teamwork, interprofessional working, overcoming obstacles, etc. So engage in those. I know it can be a bit cringy doing a mock interview with somebody that you know, but I've never not known somebody say it paid off for them in the long run. And finally, ask to visit the labs. I think that gives you a much better understanding of the type of analyzers you'll be working with. I think it lets you show your face to somebody and show that you're interested. If you're willing to take time out of your personal schedule to go and visit a lab, I think that shows you are a much more proactive person than if you ask me or Tahmina as your lecturers to get in touch with somebody for you. So I hope that all makes sense. I'm aware that it was a lot to get through in an hour, but I wanted to try and whiz through that last bit to leave time for questions. So on that note, if anyone's got any questions, I think now's a good time to open it up. And there's my email address if you have got anything you want to follow up on or speak to me afterwards about.
Thank you, Aimee. That was really good. And I guess it just reinforces how we needed an hour really for the specialisms. Going back to Biomedical Science Day and having 10 or 15 minutes per specialism, it's just not enough. There are some questions in the chat, so I'm just going to go in sort of the order that they came in. So one of the students have asked, you know, the case studies that you presented, did you learn all about them during your degree or during completing your IBMS portfolio?
Okay, so I would say that the level I was talking to you about the case studies today and my depth of understanding came from several years of experience in the lab. So when you're first going into a lab as a trainee, what I'm looking for more so is that you have the understanding of the things in the registration portfolio. So quality, health and safety, all of those transferable aspects. Lab expect to teach you the specialist morphology, for example. You should have underpinning knowledge of that when you finish your degree from your various modules. But looking at morphology, for example, you would have specialist training on that. So please don't panic if the cases I was showing you, you think, oh, I don't know what that is at the moment. Because we all learn about those things as we do our portfolio and more so our specialist portfolio, I'd say. Would you agree with that, Tahmina?
Yeah. Yeah, thanks, Aimee. The other thing is as well, aside from like the training in the lab and the degree, if there's any sort of, like you've joined today, if there's any sort of extracurricular activities or anything you can engage in, do try and engage in those, because a lot of the things that maybe hasn't been covered at uni or you've not come across yet, it might contribute as evidence towards a portfolio. So, you know, if there's any opportunity to get involved, then do try and sign up. Another question, do you perform any tests on IDA samples to determine the type of IDA present, such as nutritional IDA or functional IDA, iron deficiency anemia?
Yeah, so there's a full panel of iron studies that are performed by the clinical biochemists usually. Iron studies are a funny one because we normally pick them up in haematology, then send them to biochemistry for the functional analysis aspect. So we can tell a lot from the blood film morphology. In some cases, they might even have bone marrows performed to tell us a bit more about that side. But then the biochemist will perform things like total iron binding capacity. They'll perform things like your ferritin, which can be used as an acute phase marker, so doesn't really tell us as much. That your transferrin, your saturations, and so on. So yes, iron deficiency is usually much more thoroughly investigated, and also to rule out any other causes of iron deficiency as well.
Thanks, Amy. Another question, I think you've covered it. What's the importance of going on a lab tour before interview?
Yeah, I think it's a good chance to represent yourself to somebody. You know, if you think of how many emails these lab managers will get from students from all different universities asking if they can come in, how many of them want work experience, it's a competitive and it's a tough environment to be in. If you can get in yourself and you can show that you're professionally presenting yourself, that you're actively interested, and also that you gel well with a team. So if you've got a stranger giving you a tour, and you are proactive and you take an interest and you say, oh, what's that analyzer doing? And a lot of people don't realise when they get offered a tour at the end of an interview that they're assessing you there really unofficially to see whether you fit in. And I think that lab tour is an important way of doing that. Also, it just gives you a much better understanding of what type of equipment's there and the type of things you might be asked at interviews, and lets you see for yourself whether that lab is somewhere that you want to go to work. So I think it's always a good idea to go.
Yeah, and I think as well, if you go on a lab tour before you've attended an interview, you can always sort of look at the common tests that are performed in that lab. So then when you do turn up for an interview, and they might ask you, you know, what do you know about us? You'll be able to say, well, I know that these are the common tests that you perform. So again, it just makes you stand out that one bit extra. And like I said earlier about engaging in extracurricular activities. So when I joined the university last year, I organised some pathology lab tours for students. So we had two groups of students. I think it was about 20 in total that went to two different trusts. So if you do see an opportunity like that come up and you are interested, then do sign up. Sometimes it's easier doing it that way than contacting labs, like Amy said. Training managers and lab managers are really busy, they might not respond. So if something comes up at your university, try and take up that opportunity if you can.
Definitely.
Just scrolling through. Another question for the interviews for students that want to secure a placement, what type of questions would be asked? Would you have to know certain terms? So the IBMS are doing a support hub session actually in a couple of weeks' time that is for interview preparation. So that might be a good session to attend if you can. I can't remember off the top of my head exactly what date it is, but there will be communications from IBMS coming out on that one. There was another one. Is the molecular pathology section within haematology and blood transfusion?
That really varies by trust. So where I worked at Royal Stoke, it wasn't part of the routine haematology service. Molecular pathology was a send-away test. We sent all of ours to Birmingham Medical School, where they had a more specialised team of consultants and also more specialised analysers available. Molecular pathology tests tend to be really expensive to run, so usually they are pooled in one specialist site. But what was interesting was that obviously you got the reports back, and then you could link that with what you could clinically see for the case. So I think it's becoming more and more prevalent, and as we move more towards personalised medicine, you'll probably see it increasing across all of the different trusts, but it's not a common part of all haematology and transfusion labs.
Thank you, Amy. I'll just take this question. What if I work in the biochemistry lab during my placement, but I have more interest in haematology? When I seek my job after I graduate, what qualities for skills do you want from the candidate to make sure they are more passionate in haematology than biochemistry?
I think it's fine to be honest about that, and a lot of labs now work as blood sciences. So rather than the traditional haematology and transfusion or biochemistry, a lot of labs work where you will do both of those specialisms. So I think having blood sciences experience is what I would personally big up on my application. I think you could maybe talk more about some of the types of work that go on in haematology and transfusion, the conditions that you're interested in, like sickle cell anemia, or the types of testing, so providing that emergency blood product support. That is what I would talk about, but you're not disadvantaged by completing your registration portfolio in another area, because as I said, the registration portfolio is transferable across all disciplines, so don't let something like that put you off.
Thanks, Amy. We'll just take a couple more before we wrap this up.
Yeah.
A question in the chat again. I've done my IBMS registration portfolio, but I haven't registered with HCPC yet. Do I do it now or wait till I finish my degree?
You've got to do it when you finish your degree, because you need the accredited degree and the registration portfolio to register. So you can't do it before your graduation.
The HCPC will ask for a copy of your certificate and to prove that you've completed an IBMS accredited degree.
Yeah.
Okay. Someone's asked, should we mention that we've attended the IBMS specialism talks in an application or an interview?
I would mention any IBMS support hubs that you go to. I would mention any of the extracurricular stuff that you do at university. I know both Salford and staffs do lots of extracurricular things to support applications to biomedical scientist posts. So I would mention everything that you do that is above and beyond, even if it's just a quick mention as part of an interview question, or when they're asking for attendance on extra courses and so on. That's a good place to mention it.
Yeah, and I think as well, you've got to think about how competitive it is. What makes you stand out? All the students will complete a degree. If students have been lucky enough to secure a placement, they'll have completed the portfolio. But when it comes to an interview, and you've engaged in these activities, in these sessions that are online or in person, you can demonstrate CPD and just being proactive in terms of, your personal and professional development. A generic question, not completely related to this talk in particular, but what is a common mistake that people make in the application and interview process that you wish people didn't make? So I think maybe just mention one, Amy, otherwise it can get quite long.
I think the first one that comes to mind is not knowing the difference between the HCPC and the IBMS, which I mentioned at the start. Know the difference between your professional and regulatory bodies. They do very different work, and you'll work with them very differently. So just in the interest of time, I think that's probably all I've got time to say on that one.
Thank you. And also just as well, when you do write an application, I've seen before where someone said, I'm an aspiring clinical scientist doing a biomedical science degree and I want to work in a lab as a biomedical scientist. Kind of know your differences between a clinical scientist and a biomedical scientist. There's different career routes and pathways to those different job titles, which might not be obvious, but once you start reading into it, you'll know that there is a difference. Okay, is the portfolio completed before placement or during the placement?
It's completed during your placement. That's the point of doing your portfolio on a placement. That's why you have to be in an IBMS accredited lab. But there are components for the knowledge that you could complete beforehand. So things like statements on equality and diversity, you can learn about at university. Again, I know staffs in Salford, and I'm sure lots of other universities do lots of extra bits like that, so that you could have a decent chunk of the portfolio completed beforehand, but ultimately the portfolio is to show your experience in a lab, in a practice-based setting, so you can't do all of it before you go on a placement.
Yeah, it might be worth just printing off a reference copy from the IBMS website. So if you print off a copy and have a look at what knowledge aspect you've completed at university, you can start gathering pieces of evidence that tick off some of those standards. And again, that is something that employers again would look out for at an interview, just because you've demonstrated being proactive and taking that initiative to start the portfolio. So it is 1 o'clock, so I'm going to wrap this up. A really big thank you, Amy, for doing this today for everyone. We've had quite a lot of students join from different areas.